This CME activity is jointly provided by the Queen's Medical Center and UH-Jabsom Department of Geriatric Medicine. We offer free continuing education for this series. In order to receive a CME or CEU, participants must complete the online evaluation at the end of the webinar. Your comments are very important to the planning committee and will be used to plan future programs. About ECHO. We want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO model goes, all teach, all learn. So it will take all of you to create this community of learning. In the spirit of aloha, we encourage you to turn on your cameras to help us build a community of learning. Feel free to eat during the ECHO session. Good nutrition is key to a healthy lifestyle. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open the time up for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to the topic of today's lecture. We only ask that you keep it HIPAA compliant case for discussion. That means, please do not share patient's name, birthday, address, and so on. We learn best from our patients. They are the best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I am Lynette Gaylord, president of ARCA, Alliance of Residential Care Administrators. Maribel Tan, president of Foster Family Homes Association. Elsa Talavera, president and CEO of All Island Case Management Corporation. Brittany Pacheco, health coordination manager for Big Island and Kauai. And LTSS coordinator from Aloha Care. I apologize, but we do have someone sitting in today. I did not, if you want to introduce yourself, I'd appreciate it. And we also have Dr. Rita Bell Fernandez from University of Hawaii. We just finished a 4-month series on mobility. If you're interested in viewing any of those lectures and handouts, you can find them on our website. Unfortunately, we cannot offer certificates of attendance for videos you have viewed. You must participate in our education live. We are now on the 2nd month of a 4-month series on medication. The title of today's webinar is Alzheimer's Therapies. Leqembi is not for everyone. What else is out there? It now gives me great pleasure to introduce our speaker for today. Dr. Liow is the director and principal investigator of the Alzheimer's Research Unit, Memory Disorder Center, founder of Hawaii Pacific Neuroscience, and clinical professor of neurology at the University of Hawaii John A. Burns School of Medicine. His team serves 20,000 patients from all of the Hawaiian Islands. He is making a global impact with more than 40 clinical research projects undertaken and with over 50 residents, medical, and research students on rotation. We just heard on the news about the new Alzheimer's disease drug approved by the FDA called Leqembi. Dr. Liow was part of that groundbreaking research. It is so timely that we have him as our honored guest speaker today. Welcome, Dr. Liow.
Thank you so much, Lynette. Hopefully you can see, are you able to see my slides now on share screen?
We see you, doctor.
Okay, let me go ahead and share screen here. There you are. Hopefully you can see the slides now.
We're good.
Okay, perfect. Thank you. Thank you. That's a very kind introduction. I appreciate it. And thank you, Dr. Fernandez, for asking me to contribute to this very important seminars, and congratulations on such a successful program. And I know that there's a wide variety of audiences today from various care homes and care facilities, so that you are really my heroes. You are on the front line of taking care of so many of our patients, and I do appreciate so much all the care and all the excellent care that you have rendered to our patients. So I am privileged and honored to be part of this. So today, what I wanted to talk to you about is some of the new things. Everybody know that lecanemab or Leqembi is been approved last year, but we have been very fortunate, been able to be part of the lecanemab clinical trial since 2019. So this is the fourth year that we're providing our patients with the lecanemab. We do still have patients that are ongoing lecanemab here at our center, and but obviously I wanted to perhaps give some good perspective on what patients are great candidates and what are not. And perhaps if they're not great candidates, what are some of the options available? Because patients are always asking you what's available and what can I do? What do I go from here if lecanemab is it suitable? Is it not suitable? So hopefully this would be helpful to you. So some disclosure, this is some of my research funding. And then if anybody else wants to fund me, tell them to come and talk to me. I'm also on the editorial for Neurology International. I serve on the review study section, grant review panel member for NIH, NIDS, and also for CDC. So, so everybody knows about some of the drugs that you're very familiar with: donepezil, Exelon, Aricept, Residine, Namenda, Momentin, Namzaric. So what's really different from a drug like lecanemab or Leqembi that your patient or the family have been asking about? So the difference is that the drugs that we've been using for years, donepezil, Momentin, are what we call symptomatic treatment. They treat the symptoms, but they don't treat the disease. They don't treat the biology. They don't slow it down. They don't stop it. We don't have a cure, even with the disease-modifying treatment. It's not a cure. Make sure you let the patient understand it's not a cure, but maybe patients on lecanemab slow the decline by 22% compared to placebo. It's not a cure. So here's a nice graph of when they're not being treated. The severity of illness is the yellow line. When you have symptomatic treatment, they could improve the red line. They can improve a little bit and then they decline. So disease modifying, we hope to at least slow down the progression. Hopefully you understand the difference. The way that I explain it to my patient is I say, well, if you have a knee pain from a broken tendon, I can give you Tylenol for the knee pain. But does the Tylenol fix the broken tendon? It doesn't. It just takes away the pain. So that's what Aricept, donepezil, Momentin is doing. It just treats a symptom, but it doesn't treat what's contributes to the symptom, which is in knee pains, a broken tendon, and in Alzheimer's, is the accumulation of the abnormal protein. So let's just spend a minute when your patients ask you about, well, I heard about this new drug, Leqembi, lecanemab. What do you think? Does it work? Just in short, it slows the decline by 26%. Okay, so that's important to know. It's not going to make the patient smarter. Sometimes my patients come back after being on lecanemab and say, why isn't mom getting smarter? So I just always tell them, I'm not going to be able to turn auntie into a genius, What I'm hoping to do is at least stop the decline. You can see that the gray line is patients that are not being treated, placebo. The red line is patients that are being treated lecanemab, 10 milligrams per kilo every other week. There's 26% decline. So keep in mind, there's still going to be decline, but just less decline. Hopefully so you set the expectation right for the family and the patient. So there's not, why are they getting smarter? Why is this not a cure? It's not a cure. And then obviously, everybody heard about, what about the bleeding, the micro bleeding, the swelling, the brain? What is that called? That's called ARIA, ARIA, or amyloid-related imaging abnormalities. What does that mean? So that's exactly what it means. It's caused from the amyloid and it's seen in the imaging. That's why it's called amyloid-related imaging abnormalities. Why did it happen? What happens is the monoclonal antibody, when it goes in and scrub the amyloid protein off the brain cells that's outside the brain cells, it causes a disruption in the blood-brain barrier and the permeability of the blood vessels. So there's leakage of the blood vessels. As a result, the first thing that happens is there is um, uh, 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 swelling in the brain. As you can see from this MRI picture, some swelling in the brain on the top two pictures, those bright spots. And then when the swelling in the brain, remember that the brain is a very tight space. When the swelling, it pinch on the blood vessels. So that sometimes that causes small bleeding, what we call microhemorrhage or microbleed, or localized superficial siderosis, kind of like fancy words. But all it means is little bleeding. You can see from the bottom graph, those little black dots. And so what do patients usually, so what should I be watching out for if I have a patient on lecanemab that's getting infusion every 2 weeks going, the most, actually 90% of patients have no symptoms at all. They don't even know that they have urea. Only 10%, 1 out of 10% have developed symptoms. And what are the most common symptoms to look out for? Number one is headache. And I do have patients who had headache. Number two is dizziness. Those two are the most common. And how often does it really happen? It happens in 17% of patients. I usually tell them probably about 2 out of 10. Every 10 patients that are treated with lecanemab, 2 might have it. And it really depends on a few things. Depends on genetic profile, depends, and which I'm going to talk a little bit more about. Okay, so urea, just to recap, how often does it happen when patients treated with lecanemab? 2 out of 10, 20%. And how, when patients have urea, what do they manifest as? Majority have asymptomatic, no symptoms. Only 10% are symptomatic, and the symptoms are usually headache and dizziness. We good? See, told you neurology is so easy. Everybody can learn neurology. All right. So I think that the best way to really share this message is just to do some case study, because I could go over a lot of chemistry and clinical trials data, but when it really comes to it, you want to know what to tell your patient. You want to know what to tell their families, what to tell their son and daughters on what are my options and how do I decide what's best for uncle, auntie, grandpa, grandma, mom, dad. So let's launch into it. Number one, let's look at Mr. Vascular. And these are real cases of my patient, a retired engineer who lives in Waikiki. He has a lot of vascular risk factors. That's why I call him Mr. Vascular. His mean mental status is 23. And his genetic profile is E4E4. Why is that important? That's because the risk of urea really depends on the genetic profile of patients. So let's talk about E4 for a minute. You get one set of E4 from mom and one set of E allele from mom and one set of E allele from dad. You can either get E2, E3, or E4. So if you get one set of E4, your risk of developing Alzheimer's is 4 times as much. But you get one set, if you're unlucky, get one set from mom, one set from dad, your risk of developing Alzheimer's is like 12 times. Not only are you at risk for developing Alzheimer's, you're actually at risk for higher bleeding with urea. If you have 2 sets of E4, your risk just went from about 20% to about 50% of urea. And on his MRI, this is his real MRI, Mr. Vascular MRI. The other thing is I see a lot of small vessel white matter disease. Okay, so this is his actual MRI, and you can see the shrinking of the brain, like what we call the atrophy. Those dark spots, dark lining on the outside, the brain is shrinking. You can see that that's consistent in Alzheimer's, and then you see the ventricles are big. Those are compensatory dilatation. But what you're really seeing, important, what I want to point out here is the small vessel disease here. That indicates that this patient has significant vascular risk factors and the blood vessels are already weak. And then he has E4, I believe his risk of urea is 50% or more. And the other thing is his blood vessels and his MRI findings almost reminiscent of what we call cerebral amyloid angiopathy, which is a condition where the blood vessels are very weak. So is he a good candidate for lecanemab? What do you think? Would you put him on lecanemab? I wouldn't, so I didn't because I knew he was at high risk. Okay, so what did I do? So here's why I did not. In patients with E4 in aducanumab or E4 positive for lecanemab patients, your risk went from to 14%. E4, they went for the risk of ARIA in aducanumab patients to 64%. So they really, compared to E4 negative. Okay, and here are the symptoms most common in all the monoclonal antibody, aducanumab, lecanemab, donanemab, and gantenerumab. Headache and dizziness are the two most common. What did I do with this patient? Well, what I did was I knew that his main challenge is really his poor blood flow to the brain, because we know that when there's decreased cerebral blood flow, there's oxidative stress, which actually is the main reason he's having a lot of the beta amyloid deposits. That is the reason, that is main driving force for his Alzheimer's disease mechanistic pathway, leading to the breakdown of the blood-brain barrier and neurovascular unit breakdown. So what I did was I put him on a different treatment, a different clinical trial, which actually uses everybody you heard of, Ozempic, right, to treat diabetes. So Ozempic is actually approved, FDA approved for diabetes, but we are actually using it to treat Alzheimer's, in this clinical trial called EVOKE. There is good evidence that shows that when we can, Alzheimer's also has altered glucose and lipid metabolism in the brain. When we give patients Alzheimer's with Ozempic or semaglutide, they actually do better. So that's what I did with Mr. Vascular. All right. So the next patient is Mrs. Blood Dinner. Mrs. Blood Dinner is a 66-year-old reporter. She is on Xarelto, on a blood thinner, because she had a DVT while she was flying. She's actually she flies a lot to the mainland. She works for PBS, I believe. She had a blood clot on her leg while flying, so she's on Xarelto blood thinner. So MMSE is 25. Her genetic profile shows she has low risk for ARIA, but would you put Mrs. Blood Dinner on lecanemab? Who would? Who wouldn't? Okay, I see a few responses. Good, thank you. Thank you for your response. I wouldn't. Why? Because Mrs. Blood Xarelto. We know that patients on Xarelto has increased risk of ARIA. I would not put her on lecanemab either. What did I do? So what I did was I put her on a study called CELIA study, which is a phase 1b/2 CELIA study. And it's a little bit technical, a little bit complicated. I'll try to explain it the best that I can. Now, so some downsides to using lecanemab, because it has to be every other week. You have to go in for infusion. Do you know why? Because when you give the monoclonal antibody systemically in the IV, only very little bit of it gets into the central nervous system. That's why you hear about all these things, people trying to use ultrasound to open up the blood-brain barrier, which is a big barrier. That's why the patient has to get it every other week. So what some companies are doing is they are thinking outside the box. They're thinking, what can we do to make it convenient for the patient? Because who has time to go into the clinic every other week? I don't have time. I don't want to do that. If I have Alzheimer's, I want to go play golf. I want to go on a cruise. So we are actually delivering this new medicine directly into the brain through a spinal tap. Only once every 3 months, we do a spinal tap. We're delivering this medicine into the brain. What is this medicine? This medicine is called, instead of targeting amyloid, it targets tau protein. Remember, tau is inside the brain cells, amyloid is outside the brain cells. So the monoclonal antibodies works to destroy what's already been formed. But this This technique is called tau ASO. ASO stands for antisense oligonucleotide. It's actually a synthetic DNA that's formed that will bind to complementary messenger mRNA on the patients that manufactures the tau protein. So it stops the translation of the tau protein. It stops the problem right at the genetic level, right at its root, intraneuronal, inside the cell. Isn't that amazing? We stop the problem before it starts. We don't even want to wait till it gets to the amyloid stage to try to scrub it out. So this is actually very exciting, very exciting novel approach for me. So, and not only that, you only have to treat the patient once every 3 months. It does have a downside because it's still a clinical trial. You could get real medicine or placebo. We don't know that for sure. It has to be delivered directly into the brain through a spinal tap. And this is exactly what Mrs. Blood-Dinner is on right now and doing great. Next patient, Mr. Moderate Dementia. He is actually quite far along in his dementia, and this may be the patients that you have in your care facility, care home. This is very forgetful. The genetic profile is E2, and his MMSE is 13. And why is this important, MMSE? Because is he a suitable candidate for lecanemab? The answer is no. Why? Because he's too far along. For you to be qualified for lecanemab, the MMSE has to be 22 and above. Am I getting the signal? Is that most time's up here? So what I'm going to do, what did I do for Mrs. Moderate Dementia? I put her on an NIH-funded phase 2 study looking at a synaptic plasticity. This is another way to approach Alzheimer's. Instead of targeting amyloid, targeting tau, we're actually going to target synaptic function. We know that neurons, although the neurons may not degenerate, the synapses of the neuron can actually, dendritic aberration can regrow. We know about neuroplasticity. The neurons, the axons, can regrow. So this drug is a sub-Q injection every day. We have about, I would say, about 20 patients in our memory center that is currently on this NIH-funded clinical trial. Okay, just a few more patients and then we'll be done. So next patient is Miss Outer Island. Now, Miss Outer Island is actually, she lives in Kona, but she actually traveled to a lot of other islands. Her work is actually going to different islands to collect data. And she just absolutely told me that I don't want to have to go to Oahu every other 2 weeks. What are my options? I mean, the MMSE is good. She qualified. And her risks are so-so, 1, 3, E3, 1, E4. What do I do? What are my options? And also, she actually had a previous clinical trial. She has a biomarker positive for amyloid on her CSF, on her spinal fluid. So what I did was I actually sent Mrs. Outer Island for a clinic for the next generation of amyloid target. What is the next generation? This is called, doesn't have a name yet. It's called PRX0012. So instead of getting IV infusion like lecanemab is, or every other week, this is sub-Q, shot in the arm, and this is only once a month. How do they do that? So this is a high affinity monoclonal antibody that has about 12 times the binding affinity to aducanumab. You can see that. Therefore, it needs only to be given once a month, and it can be given sub-Q instead of IV. So this is also a clinical trial that we're doing. We have about 6 patients that are currently receiving this clinical trial. The other thing is for this particular clinical trial, you don't need a spinal tap. You do have to have a positive biomarker. We will actually fly you, pay for you to go to Los Angeles, get an amyloid PET scan at our partner amyloid PET facility. Get a partner PET scan, and we'll fly you back. You have the biomarker positive, and then we'll give you that opportunity. And what does it cost the payers here in Hawaii? Nothing. Cost them nothing. Everything is paid for. Isn't that great? So 2 more, and then we're done. Last 2 patients, Mr. Agitated, very agitated, 88-year-old. You may have some of these patients in your facility, and he's currently on Momentin. MMSE is 15. Is he a candidate for aducanumab? Or lecanemab? The answer is no. Why? MMSE 15. You have to have MMSE 22, okay, to qualify. So what did I do? I put him on a clinical trial. It's a phase 1, a clinical trial looking at emraclidine. And without getting into too much of chemistry, emraclidine is it's a positive allosteric modulator of M4 muscarinic receptor. Okay, too much chemistry, but it actually treats a lot of the agitation and the irritability in patients with Alzheimer's. It's actually has good effect even in patients with schizophrenia. So we're hoping that this could actually not only try to treat the memory, but also treat the agitation. So patients with agitation, I am trying to put them in this clinical trial. Again, what does it cost anyone? Nothing. Last patient, 77-year-old female, lives at a care facility, diagnosed with Alzheimer's. MMSE is 20. So she probably wouldn't qualify for lecanemab. Her main challenges are she's not interested and she's sleepy all the time. What did I do? I put her on a clinical trial, look at mevidilin. Okay, what is mevidilin? Mevidilin is also another allosteric modulator. Positive, it binds to the protein and then causes conformational change in protein structure, on D1 dopamine 1 receptor. What's great about mevidilin? It crosses the blood-brain barrier, and it's a wake promoting agent. So I try to pick this for patients who are sleepy, who's disinterested. We're looking for patients 50 to 80 or so, MMSE 13 to 24. And that is it. Lecanemab, although approved for mild cognitive impairment, mild Alzheimer's disease, MMSE 22 at birth, you do need to have a biomarker positive. What does that mean? That means that you need to either have an amyloid positive, PET scan positive, or a spinal tap that shows that you do have amyloid. But not all patients are suitable and at high risk for ARIA, amyloid-related imaging abnormalities, especially those on blood thinner, those with ApoE4, E4, those MRI has a lot of vascular disease. Okay, so consider other options. We talk about glucose metabolism or Ozempic. Those are called bioenergetics. In our world of research in Alzheimer's, called bioenergetics. You can consider tau targeting therapies like the one that we're doing right now in antisense oligonucleotide therapy, therapies that target synaptic plasticity or neuroplasticity, or the next generation of amyloid therapies that's just once a month injection instead of IV infusion, or therapies geared toward agitation. I provided my QR code and more information needed. And here again are all the therapies that are actually out there and available. Not all of them are available in Hawaii, but my goal is try to bring as much of these therapies, making it available to our patients in Hawaii as much as possible. In neurogenesis, epigenetic, bioenergetics, synaptic plasticity, tau, amyloid, so on and so forth. And I want to finish by thanking my wonderful team of neurologists and our students who are doing research with us. And happy to take any questions or anything else. Thank you for letting me tell you about this exciting findings in Alzheimer's.
Hi, I was wondering, can you hear me?
Yes, I can hear you.
Are there any risk for this medication for people who have had histories of seizures and are on seizure medications?
Yes, thank you. Great question. Lecanemab is not, seizure is not contraindicated in lecanemab. Patients can be on lecanemab. It's not a real contraindication. So that would be something that's that's the only FDA approved medication, lecanemab. The rest of them, the research therapies, it really depends on which research therapies. Yeah. So is that your question?
Yes, I was just
Okay.
wondering what the possibility is of someone with seizures in the past
Mhm.
qualifying for the study.
Some studies will be okay. We'll be able to take them, but some studies will not take them. It really depends on the study. If you're not sure, just go ahead and call us. You can definitely email me as well, kliao@hawaii.edu, and I'm happy to check for you. Keep in mind that patients with advanced Alzheimer's dementia, sometimes the hippocampal temporal lobe are so atrophied and so dysfunctional. It's not unusual for them to have developed temporal lobe epilepsy. Just like the patients with Alzheimer's patients with Down syndrome, there's a definite correlation between the severity of the Alzheimer's and temporal lobe epilepsy. Therefore, never when you have worsening of the symptoms of your patients, don't hesitate to check with an EEG, because that may be the time where temporal lobe epilepsy may sets in. So I usually have a very low threshold for EEG in my patients with Alzheimer's disease.
Thank you. I have one more question. If you wanted to be, say, for example, you have a loved member that you see where they're getting forgetful, how do you get them into a study if they were, say, for example, they were interested in it or willing to do a study?
Yeah, so different studies have different what they call inclusion criteria. So, for example, just the tau targeting therapies, they will only take patients 50 to 80 years old, while the studies for the agitation, they take patients up to 90 years old. So different studies have different, first of all, age group. The second thing is different studies have different cutoff point. For example, in approved therapy like lecanemab, the cutoff point is 22. MMSE is MMSE lower than 22, they don't qualify. We have some studies that for agitation and for sleepiness that would take MMSE down to 8. Just in general, most of the early studies, the phase 1, phase 2, that are clearly targeting disease modifying, like the tau targeting, they are usually about 22 and above. With the exception of the NIH-funded study that targets the synaptic plasticity, that particular study would take MMSE down to 18.
Thank you so much.
Alrighty. Does anyone else have any other questions for Dr. Liow?
One of the common question is for patients on the outer island is whether they can participate. I'm not aware of anybody doing lecanemab infusion on the outer islands. We do have some patients that are flying over here for their infusion, whether it's lecanemab or aducanumab. We also have a number of patients that are on aducanumab that just completed the studies. But often, as if it's study related, they will often pay for your travel and the travel of the caretaker to fly over. So, if you're interested in the study, we will actually pay for your travel to fly from Big Island, Kauai. We have patients from Maui, Kauai, Big Island, even Molokai. Will pay for your travel. That's one of the common questions that we get as well.
And how are you getting your funding? Is it through the pharmacist or the drug companies, or is it from the Alzheimer's Association? Because I'm sure it's costly.
No, I have a money tree in my backyard, just out of this no. All this, some studies NIH funded, like the phase 1, phase 2 studies NIH funded. But most of them are through sponsors, biomedical companies. So some of them work closely with NIH. NIH fund them, and then they fund some of the studies. So they are true biomedical companies, which have been very gracious. It's been very tough in the past to get some of the studies to Hawaii, because we may not necessarily, people think of Hawaii, they don't necessarily think of us having the infrastructure for academic studies as such. But thankfully, our community have been wonderful. Dr. Fernandez department, Dr. Masaki, the school, the hospitals have been gracious and kind and supported this, and the Alzheimer's Association. It took a number of years, but we are at a very good place where a lot of companies are working with us, looking for us. Our main contribution to some of the studies, for example, lecanemab, out of when they submitted the data to FDA of 1,795 patients, only one patient is Native Hawaiian and Pacific Islander. Can you believe that? We are not represented, and that one patient was from our clinic. So we really wanted some of this data that's submitted, because what works in the Caucasian population may not always reflect the physiology in the Asian and the Native Hawaiian population. So we really wanted our own island population to be represented. So we really try to really work with some of these companies to back them. Please let us do it. We want to know if this works just as well in our Native Hawaiian population or our Asian American population. So again, thank you so much for many of our partners in the community who have came alongside us to make this happen. Without them, we couldn't have done it.
This is not a
Alrighty,
question, but it's not more a comment. I just want to thank you, because there's so much advances in other diseases like cancer and everything, but I've always wondered why we're so slow with people with Alzheimer's and dementia. So thank you so much for the studies that you guys have been doing. Appreciate it.
Thank you.
We do have a question in the chat box. So how's the treatment for this medicine?
Lecanemab, till Jesus comes. It is a lifelong treatment. Yeah. Let me just say that my patients that are on it, a few of them have stopped. I do have some patients that develop ARIA. One patient in particular did develop rather severe ARIA, and we stopped it. What are some of the reasons they stopped it? I do have a few patients who just basically got tired of doing it every other week, because at the beginning they would say, "Oh, I signed up for it. I want a disease modifying. I'll be here every other week. I'll give up my golf. I'll be here." Then after like about 6 months, they're like, "Do I have to be here the week after next?" It is quite a commitment. So be sure to talk to your patients through it. It's every other week. I'll see you for IV infusion. It takes about half an hour to an hour IV infusion, and it is lifelong, unfortunately.
And Leilani says, very interesting information. I'm amazed how far science has progressed and discoveries in Alzheimer's treatment. Thank you for your presentation and your dedication.
I apologize. Is there a question somewhere that I missed?
I don't think you missed any question, but I do have a comment. For those really who are interested, I see the numbers on the screen right now, the 808, the 261-4476, and the 808-564-6141. So if we do have people that are interested in joining any of your studies, which number should they call?
For the clinic, it's 261-4476. If they're interested in the studies, it's the dedicated study line, 564-6141.
Okay, so the bottom number. Thank you.
Mm-hmm.
Everybody, please make a note of this number. Please write this number down, foster home operators and care home operators, 564-6141. I want you to know that you cannot get these medicines at Long's, Walgreens, and any other doctors in Hawaii. What Dr. Liow is offering, he is a true gift to our islands. I've had my own patients from KKV, Kalipalama, who have got this medicine free of charge. So there is no other way to get it. And he is a trailblazer bringing these medicines to Hawaii. Otherwise, it is so late. By the time it will get approved and we get all the insurance to cover, that will be 5-10 years down the road, and it may be too late for some of your loved ones. So I want you to write this number, and if you are not sure, just make a call. There is no harm in making a call, and somebody on the other side will tell you which is the good one, which is a study that they may have a chance, what are the options. So there are other people on the other side of the phone who can guide you. I think you just need to make the first step of making that call.
Thank you.
And we have a comment in the chat box. Tani says, excellent presentation. Thank you so much for your leadership in bringing these treatments to Hawaii and for educating all of us today.
Thank you. It's my honor and privilege, and certainly, and I feel very, very fortunate that I get to work with a lot of good doctors. And thank you, thank you.
So I believe someone in the chat box asked if that number, the 564 number, if the prefix was 808. Yes, it is a Hawaii Alzheimer's Research Unit. And the number again is the 808-564-6141. So yes, it is 808.
Dr. Liow, can you give us an update on which insurance companies which insurance companies are paying for Leqembi? Can you tell us the coverage, please?
Yes. The patients that are getting Leqembi right now is the patients on Medicare, and HMSA is also covering Leqembi, lecanemab. Those are the two predominant that that our patients are getting the lecanemab from. I'm not aware of other insurance that have stepped on board yet. I'm hoping that all of them will. It's not a matter of, I think it's a matter of time before they will, because this is a mainstream. Most insurance are covering it on the mainland for the past year since 2023. And I'm very thankful that our local insurance like HMSA and others are also getting on board. Very thankful for them for their support of our patients. Yeah.
Thank you, Dr. Liow.
And just a reminder, if you want the lecanemab, you do have to be MMSE 22 and above. You do have to be willing, at least right now, do a spinal tap to get a biomarker, because we don't have an amyloid PET scan yet. So those two things, make sure you talk to your patients about that. Yeah.
Gotcha. Hi, Dr. Liow. It's Carolyn. For the
Hi,
spinal
Carolyn.
tap, is it done in the office? Do you do spinal taps in the office?
No, I don't.
Okay.
I send them next door to the radiology. They have a fluoroscopic. So they really do a great job, the radiologists. And so the workup for the lecanemab is, first, we actually have a lecanemab screening team. They come in and do an MMSE. Then they pass that. And then the second thing is that you have to pass a few other assessment. MMSE is one of them. And then the second thing is the spinal tap. So we send them for next door, the radiology done through fluoroscopic. It's not a bedside. I don't do them. Radiologists did really do a great job. And also, I know that it's not required by the insurance company. We do personally screen our patients for E allele. We wanted to make sure that patients that are on E4, if they have a really vascular MRI, we wanted them to be aware of the risk of ARIA. I know that is not required, but we do it because we're just extra careful. We want to make sure that our patient understand that if they're a high risk, sometimes we try to discourage them from lecanemab.
Gotcha. And then if they're going for the spinal tap next door with the radiologist, do they also just do the MRI then if they haven't had one before?
Yes.
Okay. So just really send them to you if it's early Alzheimer's, and
Yeah.
you can work on all the imaging and everything. Okay.
Yeah.
Thank you.
Actually, yeah, it's a pretty smooth process. We got the whole team. We have what we call the Leqembi team. They come in and we just put them through the process, just like we do the clinical trials. We screen them and make sure that they're the right patients, the process down. And we have a prior authorization team that work with the insurance company, the payers, to make sure that the patients doesn't incur any out-of-pocket costs. To make sure it's there. Yeah.
Okay. Easy enough. Thank you.
Dr. Liow, for the care home operators and foster home operators, could you give us some examples or some stories? What would an early Alzheimer's patient look like in a care home or a foster home? Like, how would they know how would they even guess that their patient is early Alzheimer's?
Yeah, that's a great question. I imagine that you get patients of all kinds that are in your care home, and so the early signs are usually forgetting recent conversation. They would talk to you about a conversation that you just had recently, and they would be like, "No, we never talked about it." You're like, "Very strange. We just discussed this yesterday." And that would be forgetting recent conversation. That's number one. Number two is asking the same questions again and again. For example, they would be asking, did you bring me my pills this morning? And then 10 minutes later coming in, how did you bring me my pills this morning? I just told you. So the fact is that you can't really argue with them. They hear the information, and the information is not consolidated into the hippocampus, the memory center, and it just doesn't solidify. It doesn't make sense, and that information doesn't get disseminated to the rest of the brain. So it's usually forgetting recent conversation, asking the same questions. Those are early signs, and obviously later on, they could have. Obviously, you do have to be careful. There are a lot of different kinds of dementia. Some dementia, like frontotemporal dementia, they usually manifest with behavioral issues, temper outbursts, and predominantly speech, especially with the primary progressive aphasia. They have difficulty with words even before the memory loss. And then in Lewy body dementia, patients, they usually have hallucinations that are very specific, form complex hallucination, not just like bright lights. They're very person, animals, and they usually talk in their sleep, what they call REM behavior disorder, talk in their sleep and act out their dream. Those are Lewy body dementia. And then the patients with vascular dementia, they're also very different. They're usually very apathetic, very solemn, and they lost interest in whatever hobby that they have. And when you examine them, the reflexes are jumpy all over the place. So that's just a quick way of sorting those things out. Yeah, but they're just just so interesting. I really encourage you, if you have questions, talk with your doctors, talk with your medical directors that are in your care facilities. Get in touch with the geriatrician, Dr. Fernandez department. We want to help you. We want to be involved, and we want to help you sort these things out.
Thank you for helping us recognize the early stages.
Is there any other questions that either of us had for Dr. Liow today?
Okay,
This is a
there's
really
no more.
nice and easy audience. Usually I get really tough questions that I have to really sweat a lot. This is such a nice audience. And thank you for being so kind and gracious. One of the questions that sometimes people ask me is, the clinical trials, what does it cost? It costs nothing to you. And if you're from the island, we'll pay for your travel. They are funded by either NIH or the biomedical companies, the pharmaceutical companies. They're funded by them, so they cost nothing. And we really do think that clinical trials are important, because only with clinical trials can we develop better therapies, and we can develop better therapies for the future of Alzheimer's. So I thank you for all the patients. In a typical year, we have about 1,000 clinical trial visits at our center, and I thank you to all the patients that have been willing to participate in clinical trial, including the one in Leqembi, and many of because of them, we are able to get FDA approved drug. So I want to thank all of those patients who were willing and participated in clinical trial.
Okay, and we have a question in the chat box. So from the time a patient is diagnosed with Alzheimer's, how soon are they able to get into the research studies? How severe it is? And in some cases, do they forget how to breathe?
So the different clinical trials, different program will consider different patient groups. Actually, the good news is that most of the clinical trials will consider patients who are totally asymptomatic, meaning that they're not even forgetful. The MMSE may be 30, but they do have a biomarker positive on the spinal fluid. They do show early changes. Just keep in mind that by the time that you have memory loss, there's a good chance that whatever has been going on in your brain, the synaptic dysfunction, the protein deposition has been going on for the last 15 to 25 years. So a lot of clinical trials are actually targeting patients who are what we call asymptomatic, preclinical, pre-symptomatic. So we will consider patients that are very early. As a matter of fact, you get the best chance to actually turn things around, change the course of your disease, stop the progression, as opposed to patients who are coming in to the process who are very late. There may not be much that we can really do for you. So we do encourage patients, even in the early stages, we do want to talk to you, because that's really the best time to really make a difference for your loved ones.
And so Donna wants to confirm that the medication is to slow the progress of memory loss. Is that correct?
Yes, lecanemab. Patients on lecanemab has 22% less decline than patients on placebo. That's correct. On 10 milligrams per kilogram every other week. Yeah.
Alrighty, and we got a few minutes left. Anyone has any feedback, comments, questions for Dr. Liow? Okay, so we have a question. Let's say the Alzheimer's is severe. What is the lifespan for that? Is there any?
Just in general, we think that once you get to the symptoms, the average lifespan is anywhere from 5 to about 12 years. Some shorter, obviously, and some a little bit longer, just in general.
All right, looks like there's no more question. We can go ahead and cover the evaluation. Thank you everyone for all your questions and for attending today's echo. And thank you, Doctor, for a very informative presentation. Learned so much today too. Please don't forget to complete your evaluation, and remember that in order to receive certificates of attendance and CME, if you are a licensed person, please make sure that you complete the evaluation, one evaluation per attendee. And for those of you, when you get to the evaluation, you'll be seeing these 5 questions that you're seeing right now on the screen. Please answer them. We would really appreciate that. Again, make sure that we have your correct name, your email addresses, so that you can get your certificates or your CME. For the CME transcripts, they are sent out annually in December, in case you're wondering. The link to the evaluation is on a chat. Let us know if you don't see that. And if you missed last month's evaluation, I just learned today that you can go back and complete that evaluation, but you can only go back 1 month. So when you're done with today's evaluation, you can enter last month's evaluation. Any questions about evaluation? Thanks again for all the work that you do.
Thank you.
Have a great week, everyone. Aloha.
Thank you, Dr. Liao, for an amazing presentation. You made it so simple and easy to understand these very complicated drugs and ARIA. Thank you for explaining this to all of us and making it so easy to understand, and for bringing these amazing drugs to Hawaii. We are indeed grateful to you and can't thank you enough. And I hope more patients will, and care home operators and foster home operators will call your number and refer their patients to you.